Hi, my name is Beermann, and I want to thank CAS-Nation for the opportunity to talk about ablations at Danderyd Hospital. And I'm a senior consultant in radiology, and I have been a part of the ablation team at Danderyd for the last 6 years. Those are my disclosures. My agenda today is to talk about our experiences of ablation as well as of the CAS-One system, and I'm also going to mention the MAVERRIC trial. During the last decade, Danderyd has grown into the largest ablation center in Sweden, even though the pandemic has affected the volumes a little during recent years. And as you can see, the bulk of our production is liver ablation and mainly HCC and colorectal mets. And you can also see that we often treat more than one tumor per session, which means speed is so important to us. As you have already heard, we have published this paper a few years back, and the purpose was to share our experience and present the benefits of going into computer-assisted targeting techniques for percutaneous ablations. And why did we feel the need to do so? Well, the lessons we learned were that in the early days, the percutaneous approach using ultrasound alone gave a high local recurrence rate up to 30%, which is unacceptable. That is if you define local recurrence as detection of tumor within 10 millimeters from the ablation zone within 6 months. However, with the introduction of ultrasound with fusion and especially computerized targeting system for CT-guided procedures, aka CAS-One, the local recurrence rate per lesion dropped to 13% and 9% respectively. There was no significant difference in overall survival for patients treated with MVA compared to liver resection. This was true for HCC and colorectal mets if reablation was possible. And for colorectal mets, this was supported by 2 recent propensity score analyses showing that when adjusting for factors known to affect treatment choice, MVA as an initial treatment results in similar overall survival and less complications also compared to hepatic resection. Interestingly enough, there was no noticeable learning curve, especially for CAS-One. And as we find the system so user-friendly, we use it more and more. Today, we use CAS-One for more than 80% of our ablations, and it's used by surgeons and radiologists alike. And we actually have an ongoing study where we do an additional ultrasound with fusion on patients with liver tumors already prioritized to do a CAS-One guided ablation to see if this particular tumor would also be treatable with ultrasound guidance. Out of so far 50 patients, 47% were almost impossible to detect or ablate with ultrasound. And for another 35%, ultrasound guidance would have been demanding. And this means that I would have been hesitant to treat at least half of those patients without the CAS-One system. So let's look at this system. This is just a summary of the workflow, and we will go through it. But first, the setup. The cart is the main piece. It's 2 touch screens and an optical camera. We have instruments, those are fixed and sterilizable. We have a board, carbon board fixating the patient, and the consumables set. This is used 1 per procedure and has the tracking spheres that allow the camera to recognize the patient as well as the ablation needle. And it all comes with a training phantom, so you could actually practice before starting treatment on real patients. those are the different steps. You need imaging, of course, and usually it's CT. When you have your CT and your tumor, you do your planning of trajectories and you navigate your needle in place. Then there is a validation step to see if the needle position is correct, and if it is, you go ahead and treat. And you can use all devices, MVA, RFA, IRE, cryo, or even just take a biopsy. Then you verify with a new CT scan, and you can use the ablation or your PAC system to see if you are satisfied with your treatment. Let's look at the CAS-One in our institution, how we use it. We use it for tumors in liver and lung, not kidneys in our hospital. It is used in other centers, I know that, but we find the kidney too mobile for the CAS-One. It's mandatory with general anesthesia when you use CAS-One, as the patient needs to be absolutely still during the procedure. You can choose the supine or prone position depending on where your tumor is located. Let's look at the protocol for CT imaging if we are looking at the liver. Because I think you need a high dose of contrast media, as high as the patient can tolerate. You need high radiation, and it really doesn't matter because those are malignant patients. So the most important thing is to visualize your tumors. And that is also why we always use at least two phases, the arterial and portal venous phase, and for HCC we also add a late phase. You need the organ of interest to be as still as possible during the procedure, and it is possible to use apnea or tube disconnect, but we prefer high frequency jet ventilation in our institution. That is artificial ventilation with small tidal volumes delivered using high frequencies. And we are talking about 220 breaths per minute. This reduces the amplitude of respiratory movements, and you get an almost static conditions of upper abdominal and intrathoracic organs. And when you have your anesthesiology on board, it can be used safely in most patients. This is what it looks like in our institution, the actual system and the patient placed in the CT scanner with the tube in place. And when you have come thus far and you have your image, it's time to start the planning. You mark the tumor, it's the red circle, and then you choose your device. And depending on energy and time, you will get an estimated ablation zone, that's the green circle. And you can also choose your margin, the orange circle. So you can estimate if this is a good way to approach this tumor. You can also look at it in different projections, which might be really useful. And then you want to achieve this image by fixating your arm, using your shield and the micro screws to adjust the trajectory and the angle of the needle. And then you're good to go and place your ablation needle. After that, you do a verification scan, no contrast, just really fast over the needle, and you mark your needle and you get your position. And this was not a perfect hit. You can see that it differs a bit from what we planned, but from this estimated ablation zone, you can still see that it will cover the tumor and you don't need to replace your needle. When you have done your treatment, you do your verification CT and you evaluate. So let's look at the MAVERRIC trial. A busy slide, but I have highlighted the important facts. The study wants to prove oncological non-inferiority of MVA versus liver surgery for tumors suitable for both hepatic resection and percutaneous MVA. And if so, the patients were treated with MVA and the CAS-One to ensure reproducibility. And the primary outcome of the study is 3-year overall survival. For controls, that is propensity score matched patients subjected to liver resection and identified from the Swedish liver registry. In Stockholm, those study objects were identified at the liver NTD, and during even calendar weeks, 52 patients were treated with percutaneous MVA using the CAS-One for guidance. But during uneven weeks, the patient who met the inclusion criteria were instead resected, and thus constitutes a control group. So we have a Stockholm subgroup that is really comparable. And 2 students have looked at this material. It's yet to be published, but I will give you a sneak peek. There was no difference in overall survival at 24 months between the groups. For the MVA group, there was less complications, less time spent in hospital post-operatively, and lower total cost. I will come back to that in a minute. It was a high recurrence rate in the MVA group, but that was total recurrence, not just local recurrence. As you can see here, this is what it looked like, but it was no difference in pulmonary metastases, and it was actually more extrahepatic metastatic disease in the resection group. And as I have already said, overall survival, there was no significant difference between the group. And here it's 48 months after inclusion, so it's quite a while. A simplified cost assessment taking different aspects of treatment into account showed lower total cost for the patients treated with MVA, as you can see. And if you look at the per patient cost during 2 years from treatment, it was about 260,000 Swedish crowns less for patients treated with MVA. And that adds up to around 25,500 euros. So you can save quite a lot of money if you treat those patients with MVA. And as I said, it was less serious complications as well. So it's probably a good option for the patient. My take-home message will be that for selected patients, percutaneous microwave ablation seems to be a good and cost-effective alternative to resection. However, it requires a reliable guiding system for you to be able to visualize and treat tumors independent of location and patient factors. Thank you so much for listening.